Thank you, Prof, for that most informative and excellent speech. My name is Usha, and I'm a psychiatrist in Brisbane. I've had an interest in patients with autoimmune illnesses, and my special interest is more perinatal mental health. And I avidly look for some of the anti-DNA, antiphospholipid syndromes in women with recurrent miscarriages. The question I'm posing is, I'm currently treating a patient who has been recently diagnosed with systemic lupus erythematosus. She presented, she's 48 years old and presented to her GP in October 2012 with depressive symptoms in the context of multiple psychosocial stresses, and was treated with various antidepressants and had lots of failed trial to various causes. She presented to my practice in February this year, and as she walked into the door, initially it was unusual that she had a very long-sleeved shirt with a jersey. And from history taking, I had an index of suspicion that there could be an underlying autoimmune illness. She had typical alopecia, and I wondered and commented on why she was wearing long sleeves on such a hot day. And she says, she developed some rashes and she couldn't do her gardening anymore. So when I looked at it, it looked like discoid lupus. So I referred her to a rheumatologist. And by March, she was diagnosed with systemic lupus. She was put on Plaquenil, and her SLE, the activity indexes have decreased. She's come in with anti-DNA, antiphospholipids, all of that positive. I've been struggling managing her depression. She's currently on Plaquenil and on Mobic by the rheumatologist. I've tried several SSRIs, SNRIs. The thing is, there is recurrent sweating, night sweats. And I wasn't sure whether it's part of the SLE, and my avid readings doesn't point it out as a significant factor. It could be a side effect of some of the antidepressants. I have changed antidepressants. I even had her on a period with no antidepressants. There's recurrent night sweats. I've excluded tuberculosis and all of the things because I've practiced in South Africa, so I'm very aware of all of the other causes of night sweats. So extensive workup has not revealed any of the other things. What do I do? It's the night sweats that's quite debilitating, that's depressing her. She did respond to one of the SNRI, but I had to take her off it because of the night sweats. She is currently back on a SSRI, and I've sent her for a second opinion to look at ECT and transcranial magnetic stimulation to help with managing her depression. She's lost a significant amount of weight, and there's no pickup of any malignancies underlying this. And I was, it's good to hear that there's a less rate of malignancies associated with SLE. So is there anything that I can use to prevent sweating in such patients? Or just comment on that?
Yes, is this live? Can you hear me? Yeah, it's something that we do occasionally see. You've excluded thyroid and other hormonal things as best you can. We did see sweating abnormalities in some of those 13 patients with autonomic problems, and the first thing is Plaquenil, very useful medicine. We tend to use one a day, but something like that you would increase to 2 a day, 400 milligrams daily. It's a useful drug because it's got a very slight aspirin effect, so that there's an anti-platelet component to it. I totally agree with you. You're in a dilemma because you do not want to give anything more severe than that. But if a serology is still at the age of 50-something, is still strongly positive, then you've got to think that lupus is the cause of this, and you might well think of more aggressive trial of treatment. Now, in terms of the antiphospholipid syndrome, is she headachy or any of those syndromes?
Her antiphospholipids are negative.
Negative. Sorry, I thought you said positive. In that case, the first move always is to increase the Plaquenil for a short period of time. It's used worldwide. It's a safe medicine. It doesn't affect pregnancy. It doesn't in younger women, and it's without ocular problems. You're then stuck. You can give a short trial of steroids, which is the last thing one wants to give, but it would give you an indication of whether that would bring any improvement. What we are using a lot of in patients like this, where you're in a real dilemma, is MMF, which is actually a very safe medicine, mycophenolate, very expensive, but in small doses, rather than steroids. And I don't know if that's something that you considered. But it's a common combination to have discoid lupus, to have, I mentioned earlier, thyroid problems, very, very common in this group of patients, and Sjögren's syndrome with very dry eyes, skin problems, sweating problems, and you treat them the same as you would a mild lupus. But not an easy one. I don't have an easy answer for that.
Thank you.
Sorry, I'll just bring this. I'll just bring this.
This has probably been one of the best psychiatry lectures I've been to for a long, long time, physician aside. The question I've asked, if it's a clotting disorder with the phospholipids, what's the longitudinal history? Does it unclot and get better? Is it a relapsing and remitting condition? And the other question, I've got probably about half a dozen patients that I'm feeling incredibly guilty about for having missed what you have described, and which I've probably got to investigate. And I see a lot of little kids with this livedo.
Do you?
Yeah, but I was wondering if you could describe it a little bit more. I mean, does it blanch on touching? Does it go away?
Yeah.
What happens with it?
Thank you very much for the comment. The livedo, the skin doctors tell us there's two types of livedo. There's those that are connected. There's racemos. They've got Latin names for them, which I don't understand. But the livedo that we see is quite connected. It's more circular, lots of interconnections, and it's very much a feature of bad news in my experience. And I think that this disease is bad disease. And my experience of it is that it doesn't go away. I'm getting more gloomy about it, untreated. We see patients whose history has been, and I'll show that after lunch, whose history has been not have been recognized and have gone on to more focal and ultimately multifocal lesions. So children, we don't have experience with children. And I was at St. Thomas's, we did, but since I retired from there, London Bridge, we don't have pediatrics, unfortunately, so we don't see children. So it's something that I'm missing out on.
Thank you.
I think in the next talk I've got a few patients that I'll be presenting where I come across similar challenges, and maybe we'll have a discussion then as well as to what happened in those cases.
Patrick Lawapierre from Melbourne. Just a short question. There are newer anticoagulants being used today. Any use in preference or as an alternative to warfarin or Coumadin?
Yes.
Yep.
Thank you. That's a good question. The new anticoagulants, where the drug companies are desperate for them to work and make money, and we're desperate for them because warfarin is such a pain in the neck. The answer is we've been reluctant so far to try them in a big way for a couple of reasons. Firstly, the dose seems to be the same in big men and little women, and this seems to be such, we've seen such variations in the requirements for warfarin in these patients. Secondly, there's the worry of lack of an antidote, which have been case reports in America particularly. So at St. Thomas's Hospital, they're in the middle of a trial at the moment in antiphospholipid syndrome of the new anticoagulants, dabigatran and so on, compared with warfarin. So I'm really rather waiting for those. Our cardiologists love these drugs. They're using the new anticoagulants all the time. So I guess they will be coming in much more, but I again don't have the experience of them to comment. I should say the website at the bottom here, for what it's worth, I produce a monthly blog called Patient of the Month, and it's each month as a patient and what's the lesson from the patient.
My name is Josh Geffen. I'm from Brisbane. I'd like to echo the other comments. Thank you for an excellent talk. I've got two comments. One's about a patient that I've got who has identified SLE, temporal lobe epilepsy. Many of the neuropsychiatric symptoms described are difficult to treat depression. She also has an AV malformation, which has had a history of bleeding. And only last week, she's treated by rheumatologists and so on. She's often on long-term steroids, as well as on non-steroidal anti-inflammatories. And only last week, she's had a GI bleed and has dropped her hemoglobin of 40 and is in hospital. Interestingly, she's also got a teenage daughter who sees a child psychiatrist in our practice, and I'm a bit interested in screening her as well. I've got a bit of a problem now if I want to talk to them about recommending anticoagulation therapy. Yeah. How important is this, and how would you approach it if I'm going to talk to the colleagues who are managing her various risks?
Thank you. Yeah, no, this afternoon I'll talk about families with temporal lobe epilepsy. It's something that we do see. I mean, it's a major problem. You're walking a tightrope, aren't you, between bleeding and clotting in some of these patients. Of course, I'd stop the anti-rheumatic drugs, in terms of bleeding, but there's no easy answer. Steroids, anecdotally, help slightly, but as you probably know, not doing very great things. So you may be bound to slightly reduce those and stop them. There's no easy answer. If you live in Israel, you'd use IVIG because they have access to it. But in UK, it's expensive. We don't have it in the way. I don't know if it's easy accessible here, but it carries you over in some of these difficult patients where you've got bleeding but yet clotting at the same time. For example, we have patients with very severe clotting disorder who got platelet counts of 20,000, and that really is a nightmare combination. So there's no easy answer, sorry.
Okay, thank you. My other comment was that I had a quick look, because some of this is very new to me, that apparently the prevalence of positive testing for antiphospholipid antibodies is about 6% in the general population.
Yeah.
And then the question is, what happens to those people who have no symptoms, no syndrome, but have a positive test? Do we have any answers on that as yet?
No, we don't. We have a charity in England that's trying to raise awareness, and those figures are hard to come by. We talk about 1% of the population, but we don't know. It's like the early days of cholesterol, do you go out and screen and test? I mean, what most practitioners do is advise baby aspirin with your Weetabix every morning and hope for the best, That's as far as our knowledge goes.
Thank you very much.
There's, for a long time now, existed evidence, Greg Pearson from the Gold Coast, a lot of evidence for lithium and its neuroprotective effects on the central nervous system, and now a growing body of evidence for the use of lithium in conditions that result in recurrent cerebral ischemia. Is there any evidence or any data on the use of lithium in this condition?
No, you floored me. It's interesting. I don't know. I don't think there's any evidence, and I'm pretty up with the literature, but I've not seen that in this particular condition. Yeah. Has it got anti-clotting mechanisms?
It's just neuroprotective, and so it mitigates against the sort of collateral damage caused by cerebral ischemia.
Right.
And the outcome studies are actually extremely positive for its use in TIAs, recurrent strokes, and so forth.
Yeah, well, thank you. That's new to me.
Okay, thanks.
In the next talk, I'll be talking a little bit about just what you mentioned and the immunomodulatory effects of lithium. In the next one. So I think we'll generate a bit more discussion.
Okay, thanks.
Professor, very quick question. Thank you very much for your fabulous talk. Just a very quick question. Do you ever diagnose Hughes syndrome without positive markers? Do you ever diagnose it clinically? So you said 80% of cases have anticardiolipin antibodies. Do you ever make a diagnosis purely clinically?
Absolutely yes. Absolutely yes. And it's something I will come back to this afternoon. Like all these things, as knowledge increases, we recognize that there are many people probably with the classic syndrome whose APL testing is negative. And I think it's just because we're ignorant. We don't have it's like the early days of seronegative arthritis or seronegative lupus, where subsequent tests show that there are subgroups with different antibodies. And I'm going to show a slide on that later on. But if you have someone that you strongly think has the syndrome, especially if there's a family history actually, then you treat.
It's actually a follow-on question from that. Partially you may have answered it already. So I've got a young lady who had terrible fatigue. From the age of 16 to 17, she couldn't stay awake to do her TE, the Year 12 type exam. Subsequently, iron deficiency anemia, which doesn't respond to anything. Gluten intolerance, which again is not celiac disease. She's been gastroscoped. She's had all the investigations. Been to see immunologists, depression which comes and goes and doesn't respond to anything, but the immune markers are all negative. And been to see immunologists, been to see gastroenterologists, and no real answer to anything. Would you treat someone like that?
How old is she, did you say?
She started having problems when she was about 16, and she's now 23. Her symptoms, she develops joint pain, she has Raynaud's phenomenon in her hands and fingers, terribly gluten intolerant, has abdominal pain which comes and goes, quite debilitating at times. At other times she's quite well, and it just keeps oscillating like this, and depression sort of intermittently, but as I say, all the immune markers are negative except for low platelets, hematologically.
Low platelets?
Low platelets, always had low platelets, and chronic iron deficiency anemia despite eating meat, having iron supplementation, just doesn't get better.
You're moving very strongly, aren't you, towards an autoimmune disease here?
Of some description, yes.
Of some description.
Yes.
And, you know, she's too young to be this ill, and if you as a psychiatrist feel this is not just primary psychiatric disease. There's a few things that I would look for straight away in this lady. One is a Schirmer's test. Now, I was talking about this at breakfast. You know, a Schirmer test is a piece of standardized blotting paper, a few millimeters long. Put that in the corner of her eye, wait 5 minutes, and it will be bone dry. And I'm willing to bet £5 Australian that it's dry. And how you can hold me to that. She has probably got Sjögren's underneath it. A lot of them are gluten intolerant, and a lot of them have borderline platelet counts. I don't know, I mentioned 100,000, that sort of figure. And a lot of them have, you know, the other features. And you would certainly try Plaquenil in this girl for a starter. And a lot of them are labeled as fibromyalgia, which I think is the worst diagnosis on earth because it stops rheumatologists thinking, you know. $5 Australian is that price.
Hi, I'm Deirdre Horn from Sydney. I was just wondering if if you could comment upon the changes in the frequency, perhaps, of migraine over the life cycle. If in particular, if there any change, say, postmenopausal as opposed to earlier in life, that type of thing.
There aren't. You know, what's interesting, and it really is a passion of mine, that there's very few good studies of migraine. We started a collaboration 10 years ago with a migraine clinic in St. Bart's Hospital in London, and the man who ran that then got a job elsewhere, so that came to an end. There's no good publication from migraine clinics, which is a disaster. And I mean, our own experience is that this is often starts at the age of puberty and then goes through med school or university or school or whatever. Sometimes goes away, as I've mentioned, and comes back with a vengeance in their 40s. But I mean, this week I saw a girl whose mother is a patient of mine, lifelong migraine, stroke at 45, and now I've seen and miscarriage and a late pregnancy loss, of fetal death. Now I've just seen the daughter, who's now 20-something with severe migraines, you know, and actually positive for antiphospholipid antibodies. So there seems to be a genetic tendency. Whether it changes in older age, I don't know. I don't think it is known. I don't know if there's anyone here running migraine clinics, but it's such an obvious project for someone to do.
Yes, Tony Miak again. Just questioning about the thrombocytopenia. I've seen fortuitously a number of patients with depression, psychiatric syndromes, and then out of the blue they have a platelet count of 40,000, very low. I'm just wondering, would you then, in your experience, would you go on and test them for do an ACL or an
Yeah.
LA or an
Yeah.
anti...
Yes, definitely would. I think thrombocytopenia, it's in the criteria, as usual. Some groups have got criteria together, but the borderline. We do see occasionally very low platelet counts, 10,000. Much more common, we see platelet counts of 110,000. Borderline. And there's some people believe that the problem is a platelet problem. The antiphospholipid antibodies adhere to platelet membranes and make them more sticky, and therefore, like instead of salmon swimming in the river, they all touch each other and stick. Some of our patients get this artificial low platelet count in a machine. I forgot there's a fancy word for it, but platelet count of 80,000. When you test it visually, it's 110,000, suggesting that there's a platelet abnormality. But yes, I think the platelets is a big, big clue in your patients, and I would look.
Hi, sorry, Les Koopowitz from Adelaide. Here I am, over here.
Thanks.
We've got a big problem in Adelaide. One is that rheumatologists and haematologists don't like to be told what to do by psychiatrists. Secondly, I'm having an ongoing argument that I work in brain injury and see a number of patients with Hughes syndrome and with SLE. And there seems to be a prevailing dogma there that if there is no raised ESR, then there cannot possibly be cerebral involvement of the lupus, which is not what I'm seeing in clinical practice, number one. And number two, just in answer to the earlier, my patients with depression with excess sweating, I find that very low dose topiramate in the region of about 25 milligrams not only helps with the sweating, but a lot of them actually clears their brain. Okay. I don't know why. I know about why with the sweating, but not why it should clear their brain, because they don't have positive EEGs either.
Well, thank you very much for that. I mean, you're not alone. I suppose when you're looking at something new or you're thinking laterally, you just get people who don't believe you. And we have the same problem with rheumatology in the United Kingdom and hematology, and they have different ways of looking. They, for instance, I'll show you in the next talk a letter from a GP saying patient hasn't had a thrombosis, therefore she can't have Hughes syndrome, which is rubbish. It's a matter of education, I think, and it's for me today is a great day because the first time I've talked to psychiatrists who must see a lot of these patients. Probably rheumatologists don't actually, unless the patient's got Sjögren's, see that many of them properly. As far as the ESR are concerned, I totally agree with you. Some patients with severe neuropsychiatric lupus have normal ESRs. Someone asked me earlier on about the CRP. CRP is very interesting because a sick lupus patient on a Friday night, ESR 100, CRP 0. And it's this inability to mount a CRP response that's characteristic of lupus and of Sjögren's. And unless there's infection, then it goes up. So it's a very useful test. And nobody knows why the CRP doesn't go up with infection. But I find it very useful on a Friday night case, when you really are struggling. And my colleague, Professor Pepys in London, is an expert on CRP. And he gave a lecture saying that CRP goes right down the species. It's been found in dogs, cats, monkeys, right down to the lowest animals. And no one knows why God sort of put it there, but it's obviously been kept for some important reason. And he was asked how low down the species does it go, and he said, it's been found in Welshmen. So
Hello, Sue Pavey from Sunshine Coast. I may have missed this, and I'm sorry if I have. For somebody who's got mild symptoms, did you say that you would put them on just on the baby aspirin and just monitor, and then if it got more severe, you would have heparin? And if so, is that a lifelong heparin injection? That's the treatment.
No, it's not. We always, of course, start aspirin unless they're asthmatic, or there's a reason not to. And in that case, we'll use clopidogrel. And actually, clopidogrel, does the job, although the price is much more. And then some respond, some don't. If they don't respond, we have a big problem in the absence of the new anticoagulants. It's hard to go to warfarin, although we know that in those patients with severe lesions, focal lesions, they must go on warfarin, and they do well. But between them, there's a huge gulf. And we hit on this idea 10 years ago or so, a 3 to 4 week trial of heparin based on our experience in the pregnancy clinic, that it tells you, and it really does tell you, the patients say, look, the fog's gone, I get my life back. And if you get that response, we tend to then seriously consider warfarin. Now, we have a few patients, 20 or so, at the clinic at St. Thomas's who've been on long-term heparin, but you're injecting daily, and it's not good. My Guinness Book of Records, my longest heparin patient is 5 years on heparin, and she's fantastic on heparin, but she's married to a hematologist.
We got time for one more question, but there'll be lots of other questions later on because Professor Hughes is doing the rather mysteriously named talk Tuesday at 4 o'clock, so we'll have more time then as well.
Right.
One question.
Just, it's probably a very simple question that I didn't hear. So when you use the term antiphospholipid antibodies, are you referring to a group of tests or one of the three specific you mentioned for Hughes syndrome? And also, which of the antibody tests is most important to distinguish Hughes from SLE?
The most important test is the anticardiolipin, ACL. It's cheap, it's an ELISA, it's done in every lab. And so it's the most commonly positive, and ACL is what should be done. And if you're not being quoted publicly, that's the one that really matters. If you want to be perfect, you have to do the lupus anticoagulant again. The term antiphospholipid is a generic term for all the tests. And when we described it in the Lancet in 1983, we described the syndrome as the anticardiolipin syndrome, which I'll explain in the next talk. But it's wrong. It could be antiphosphatidyl-serine or antiphosphatidylethanolamine. We thought it was an antibody against any phospholipid. That was wrong too, because antibodies only react against proteins, and sure enough, it became recognized that you needed a protein as well called cofactor. And so the full title would be antiphospholipid protein complex antibody, which is rubbish, So it's getting, as usual in clotting, it's getting more complicated.
And the one test, if you want to do for SLE, which one would that be?
DNA.